Hello everybody. In today's lecture we are going to look at retention and relapse. Okay, now with this lecture the student should be able to define what is retention and what is relapse, should be able to identify the etiology of retention and relapse, and outline the methods of retention, classify the type of retention devices, and explain the theories behind the concept of retention. Now, there are three concepts that we will look in. One is retention, two is stability, and three is relapse. So, what is retention? Now, retention is the final phase of orthodontic treatment which aims to maintain or retain the teeth in the corrected positions after completion of active tooth movement. Now, although it is the final phase of orthodontic treatment, the planning for retention should be done at the treatment planning stage itself and not left till at the end. Now, without retention, various factors will cause teeth to move away or relapse from their final post-treatment positions. Why do we need retention? Now, it has been shown that after tooth has been moved, the gingival and periodontal fibers takes a long period of time for reorganization and readaptation. And in the case of supracrestal fibers, it has been shown that it can take up to 232 days for reorganization and readaptation of the supracrestal fibers. Now, the final occlusion is unstable, leading to a relapse tendency. Okay, and continuing growth of the jaws after completion of treatment can also give rise to relapse. Now, there are various schools of retention which have different opinions on retentions. Okay, now philosophies to explain factors determining stability of final occlusal position of teeth after completion of active movement of teeth. Now, what are the schools of retention? Now, there is a occlusion school of retention. Now, whereby it's stated that the establishment of proper occlusion after treatment ensures stability of the corrected position of the dentition. Okay. Now, the next school of retention is the so-called apical base school. Now, according to this school of thought, the apical base is the most important factor in the maintenance of stability of the corrected occlusion, and thus the intercanine and the intermolar width must not be altered with treatment, and arch length cannot be increased significantly. Okay, now the mandibular incisor school of thought holds that the mandibular incisors must be kept upright over the basal bone to maximize stability. Okay, now there are four types of relapse. Now, the first relapse is a relapse in alignment, whereby with relapse, crowding of the teeth reappears. Now, the second type of relapse is in the vertical direction, in which with relapse either the open bite worsens or the deep bite deepens. Okay. Now, the third type of relapse is the sagittal or the anterior posterior relapse, whereby it leads to an increase in overjet or increase in reverse overjet. The fourth type of reverse relapse is in the transverse direction, whereby we see the reappearance of a cross bite. Now, what are the causes of relapse? Now, there are 4 or 5 large groups. Okay, here it's outlined the 4 groups. One is the periodontal and gingival factors. Number 2 is a soft factor. Number 3, growth factors. Number 4, occlusal factors. Now, some um, investigators also mention fifth factor, which is the habits. Okay, whereas some authors include it within the occlusal factors. Okay, now what causes relapse? Now, one is a periodontal factor. Now, when teeth are moved, the periodontal fibers and gingival fibers are naturally stretched. Now, contraction of the stretched fibers tends to cause relapse of the teeth. Now, the principal fibers takes about 4 weeks to reorganize and readapt, but the supragingival fibers or the supracrestal fibers takes up to about 40 weeks or 232 days to reorganize to the new position of the teeth. Now, the second factor is the bone. Now, when teeth is moved, has been moved recently, the nature of the bone is it is a lightly calcified osteoid bone. Now, this bone is not stable yet, and during retention, the bony trabecular gradually reverts to a normal architecture, meaning the fibers change from a parallel to perpendicular alignment to the long axis of the teeth. Okay, now the other cause of relapse is growth related changes. Okay, now any correction of skeletal problems may worsen with or relapse with post treatment continuation of abnormal growth pattern. So, in other words, if a class 2 is corrected and unfavorable growth pattern is still occurring, then the class 2 malocclusion will re-establish itself, and this applies for a deep overbite as well as a open bite as well. Now, another cause of relapse is the failure to eliminate the original cause. Now, all probable etiology must be identified during treatment planning and diagnosis stage, and it need to remove, and with the treatment must aim to remove the cause or reduce the severity of the cause. Otherwise, the correction will not be stable and will relapse. For example, a low frenal attachment that is not corrected will cause a reappearance of the midline diastema. Now, what is the role of third molars? Okay, is there an effect in the relapse, especially of the anterior arch, or is it a myth? Now, third molars, as we know, erupt anywhere between 18 to 21 years of age, and very frequently they are impacted or unerupted. Now, it is believed that the pressure of the erupting third molars puts a mesial force on the dentition, which results in late incisor crowding, leading to relapse. Now, but it has been shown that patients who had third molars removed experience worsening lower incisor crowding. Similarly, individuals with agenesis or congenitally missing third molars still develop lower incisor crowding later in life. Thus, there is no concrete evidence to show that third molar plays a role in relapse. Okay, occlusal factors. Now, post treatment, there must be good intercuspation of the upper and lower teeth to ensure stability of the correction. Now, the centric relation must be must coincide with the centric occlusion, and even if it doesn't coincide, it should not, the non-coincidence should not be more than 1.5 to 2 millimeters. Now, relapse can also be caused by mannerisms or habits such as clenching, grinding, nail biting, and lip biting. Okay. Uh, Other factors of relapse are tooth size discrepancy. Now, Bolton mentioned that the the width of the maxillary to mandibular teeth as an ideal ratio. Now, if we take the 12 mandibular teeth, it should be about 91.5% of the maxillary teeth, width of the 12 maxillary teeth. And if we take into account the 6 mandibular teeth, then it should be 77.2% of the 6 maxillary teeth. Now, if the maxillary teeth is relatively larger, this is usually compensated by a deeper overbite, a bigger overjet, or a combination of deep overbite and big overjet. There will be crowding in the maxillary arch, and there is a class 3 tendency in the buccal occlusion. Now, if the mandibular teeth is relatively larger, this is compensated by an end-to-end incisor relationship or a class 3 tendency, spaced maxillary arch, and crowding in the mandibular anterior segment. Now, 10 theorems of retention has been put forward to describe the different philosophies regarding retention. Okay, let's have a look at some of these theorems. Okay, now one, teeth that has been moved tend to return to their former position. Now, orthodontically moved teeth show a tendency to return to their original position. Now, this tendency can be due to possibly muscular forces, bone morphology, the transeptal fibers, and the position of the teeth over the apical base. Now, the second theorem of retention is elimination of the causes of malocclusion will prevent a recurrence. As I have already mentioned, we need to identify all possible causes or etiology at the time of diagnosis, and these causes must be eliminated if possible or reduced in severity. Now, this is especially true for abnormal muscular forces arising from habits such as digit sucking, tongue thrusting, and other abnormal pressure habits. Now, the third theorem of retention states that malocclusion should be overcorrected. Now, there is little evidence for the effectiveness of this approach. Okay, examples of overcorrection are for deep overbite correction. Now, we can finish a class 2 DIF1 to an edge-to-edge occlusion, and we can overcorrect rotation by slight rotation in the opposite direction as shown in this direction. Okay, so this is the pre-treatment position, rotated position of the canine, and if we are aiming to derotate to this position, now overcorrection will mean slightly overdoing it in this position. Okay, now fourth theorem is the proper occlusion is an important factor in holding teeth in their corrected positions. Okay, successful achievement of good occlusion after active treatment ensures long-term stability. Now, proper intercuspation of the teeth is essential for stability of the corrected occlusion. Okay, now bone and adjacent tissues must be allowed to reorganize around newly positioned teeth. Now, during tooth movement, the bone remodels. There is areas of resorption and areas of bone deposition. Now, stretching and reorganization of the periodontal fibers is also taking place, as for example in this situation with the derotation some of the fibers will be stretched. Now, sufficient duration of retention need to be given for the maturation of the bone, the osteoid bone into adult mature bone, and also the retention allows reorganization of periodontal and gingival fibers. Now, if the lower incisors are placed over basal bone, they are more likely to remain in good alignment. Now, post-treatment stability increases when lower incisors are placed upright over basal bone. Now, upright means it's perpendicular to the mandibular plane plus minus 5 degrees. Now, in growing patients, the mandibular anterior segment exhibit physiological migration or eruption pattern posteriorly. Thus, a slight lingual tilting of the lower incisors ensures less relapse. Now, difficulty arises in determining where the basal bone begins and ends. Okay, corrections carried out during periods of growth are less likely to relapse. Treatment should be instituted if possible when the patient is young and actively growing. Growth can be influenced only when the patient is growing. Any inhibition or alteration of growth direction using appliances such as headgears or myofunctional appliances must be initiated early to utilize the growth potential. Now, early treatment allows interception of malocclusion before excessive dental and morphological compensations occur, and morphologically immature sutures are more amenable to alteration. Now, the further the tooth has been moved, the more likely would relapse. Now, teeth moved a long distance are prone to relapse and also prone to root resorption. Therefore, interceptive measures are more appropriate so as to avoid extensive movement of teeth later on. Now, arch form, particularly mandibular arch form, cannot be altered permanently by appliance therapy. Okay, any alteration of arch form, especially the intercanine and intermolar widths, is likely to relapse. Many treated malocclusions require permanent retaining devices. Now, some types of malocclusion are inherently unstable. Now, such malocclusions, once corrected, will require long-term or permanent retention. Okay, retainers. Now, what are the ideal qualities of retainers? Now, retainers function to restrain each tooth from moving. Okay, and it allows functional occlusion whereby physiological tooth movement is not restricted. Now, it should be self-cleansing and permit good oral hygiene measures. It should be durable and sturdy, and it should be inconspicuous. Retainers can broadly be divided into two big groups, removable and fixed. Okay, now the removable retainers. Now, the Hawley retainer is one of the most commonly used, and it was designed by a chap called Hawley. Now, it has three components. One is the clasp, usually Adam's clasp. It's got a short passive labial bow, and it's got acrylic based material. Now, the advantages of Hawley retainer are it's easy to fabricate, the design is simple, patient compliance is good because of the reduced bulk, it can be used in both the upper and lower jaws, and it can even have bite planes incorporated into the acrylic plate. Now the disadvantages is susceptible to fracture or loss and can be difficult to insert if severe undercuts are present in the premolar or molar region. Now the Hawley retainer can also be modified in many ways. Okay, one of the modification is a Hawley retainer with a C class on the molars. Now in this modification, the Adams class is replaced with a C class. Now this is used when the occlusal contacts are tight and the Adams class may cause occlusal interference. The disadvantage is the retention of a C class is not as good as that of a Adams class. Okay, the next modification is to put a occlusal rest on the Hawley retainer. So instead of a Adams or C class, this is replaced with an occlusal rest. Again, the indication is for tight occlusal contacts and it avoids occlusal interference from the occlusal arms of an Adam. Again, the disadvantage is less retentive compared to a Adams class. Okay, the Hawley retainer the short labial bow of the Hawley retainer can also be replaced with a long labial bow. Now the long labial bow compared to the standard labial bow or the short labial bow will extend from premolar to premolar. Now the indication is to keep the premolar extraction spaces close. Now if a premolar extraction was done, the arm of the short labial bow will pass over the extraction space, and from the wedging effect of the arm, the premolar extraction space can reopen. Okay, now a Hawley retainer can also be used with a contoured labial bow. A contoured or fit labial bow fits in the cervical margins of all the anterior teeth. Now the indication is if more retention of the appliance is required anteriorly, then this can be obtained using the fitted labial bow, and the retentive function of the on the anterior teeth is also better compared to the standard Hawley because the wire makes close contact with most the whole width of the surface of the tooth. Now the advantage is it is bending the Hawley to closely adapt to all the 6 teeth can be difficult. Now the Hawley retainer can also be used with light elastics. Now in this modification, the elastic replaces the labial bow and the elastic will stretch across the anterior teeth as shown in this diagram. Now the indication is to close some minor spaces post-treatment in the anterior segment. Now the disadvantage is the effect of the elastic is more difficult to control. Now the labial bow of a Hawley retainer can also be soldered to the bridge of the Adams clasp. So the terminal end of the labial bow is soldered to the bridge of the Adams clasp. So therefore it eliminates the crossover wire. So again the indication is it can used to close minor spaces in the anterior segment. It can close any residual premolar extraction spaces, and it can also prevent the opening up of the premolar extraction spaces. A bite plane can also be incorporated in the Hawley retainer. Now this can be used to retain a deep bite correction. Now the next type of retainer, removable retainer, is a back or also known as the wrap around retainer. It was designed by this chap called P.R. Beck. Now the components, it has got an extended labial bow which extends up until the last erupted molar and curves around it, and it's got a acrylic based material. Now the advantage of the back retainer, again there is no crossover wire. Okay, so therefore there's less possibility of the extraction space opening up, and because of no crossover of the labial bow as well as no Adams class, so therefore there's less occlusal interference, and it can also be used with partially erupted molars. The disadvantage is it is less retentive compared to a standard Hawley. Now the spring or clip-on retainer is a retainer that extends from premolar to premolar, and it is the wire framework from the labial, and then it recurves to lie on the lingual surface. The wire is entirely embedded in acrylic except for the portion where it crosses over. Now, indication is to provide retention for the lower anterior teeth. Now, a Kessling tooth positioner is a type of removable retainer developed by K.D. Kessling in 1945. It covers the clinical crowns of upper and lower teeth as well as a small portion of the gingiva. Now it fills the freeway space between the teeth and is made from a thermoplastic rubber-like material. Now it is made to a predetermined teeth position. Now the advantage of the Kessling tooth positioner is durable material, no activation is needed, can be used as active removable retainer during the final finishing stage. Now the disadvantage is there is some speech difficulty with this retainer and special fabrication apparatus is needed. Now the invisible Osamu's retainer as well as the vacuum form retainer, the VFR. Okay, all of you all are quite familiar with this VFR. Now it fully covers the clinical crowns and a portion of the gingiva. It is made from a thin transparent thermoplastic material. Now the advantage is because of the transparent material is aesthetic and is well accepted by patients, but the disadvantage is special fabrication apparatus is needed. Now the next group of retainers is the fixed retainers, the simplest of which is the band and spur retainer. Now these bands are placed on the derotated teeth and spurs are shouldered onto bands, and this type of retainer is indicated for retention of single tooth derotation in class 1 malocclusion. Now the advantage is a fairly conventional design, enables good oral hygiene measures, but the disadvantage is it is unaesthetic. The earlier one is banded, now this is bonded. Now a wire is bonded on the palatal and lingual surfaces of all the anterior teeth. The wire material used can be a 0.032 round stainless steel wire or 0.032 round plain blue alloy. Now alloy is alloy of nickel chromium, and 0.030 of round gold plated wire. Now the wire is adapted on the lingual surfaces of the 6 anterior teeth. The terminal end of the wire is curved and bonded on the canines. Now this retainer will prevent the incisor from recrowding and holds the incisor position. If you look at these two diagrams, there is a slight variation. In this upper diagram, the retainer is only bonded on the canine and it merely contacts the other incisor teeth. But in this example, the retainer is bonded on all the 6 tooth surfaces. Okay, now retention after certain types of treatment. Now, after correction of rotation, there is a high risk of relapse due to resiliency of gingival fibers. Now, the solution is to uh, provide retention on a long term or prolonged term, and then to aid the readaptation of the reorganization and readaptation of the supracrestal fibers, circumferential supracrestal fibrotomy, or also known as pericision, can be carried out. Now, after correction of class 2 malocclusion, now retention can be provided with a headgear with functional appliance or a maxillary retainer to overcome differential jaw growth. Now, the duration of retention should be carried out until growth has stopped. Now, after correction of a midline diastema, a Hawley retainer can be used, or more commonly a fixed bonded retainer, canine to canine or central to central, and as well as a phrenoplasty if the diastema is due to a low attachment of the labial frenum. A phrenoplasty can be done to reposition the frenum, okay, and denude the alveolar bone, and destroy the transseptal fibers and recontour the labial gingival papilla. Now, after correction of a deep bite, a removable retainer can be provided with an anterior bite plane incorporated, as in a modified Hawley with an anterior bite plane. Now, after treatment of cleft palate cases, long-term retention is required. Sometimes even lifetime retention is required, especially in the days before alveolar bone grafting was done. Then retention is required to prevent recollapse of the arch. Now, retention can also be enhanced with adjunctive procedures. Now, two of these adjunctive procedures has already been mentioned. One is the pericision or circumferential fibrotomy. The next other one is the phrenoplasty or gingivoplasty. Now, a surgical gingivoplasty can also be done to remove excess or bunched up gingiva after extraction space closure, okay, and it enhances the stability of the space closure. Now, finishing procedures can also be done to increase retention. Now, root paralleling of teeth adjacent to the extraction site should be done to ensure that the extraction site space closure is stable. Now, with this paralleling, then the possibility of the spade opening is reduced. Now, interproximal stripping. Now, this is normally done to idealize the mesiodistal to buccolingual ratio. Now, the mesiodistal to buccolingual ratio for mandibular central incisor is 0.72, and for the mandibular lateral incisor is 0.95. Now, this can help to enhance stability, though it is not a proven procedure. A trial setup will be needed before the actual procedure, and up to 0.25 millimeter can be removed from each proximal surface. Now, there is adverse effects in this procedure which is a normal abnormal contact relationship and root proximity. The standard retainers are usually passive, meaning they do not um, put active forces to move the teeth. But retainers can also be active to achieve a small amount of tooth movement during the retention phase because of relapse. Now, Hawley with a palatal acrylic can be trimmed and the labial bow can be activated for minor tooth movements. A wrap around retainer with a bow activated can be used to close band spaces. Okay, and the spring retainer can be utilized for minor lower anterior segment realignment. Now, Raleigh Williams mentioned 6 keys or 6 features to ensure the stability of the lower incisors. Now, the first he mentioned was the lower incisal edge should lie on the apogonian line or about 1 millimeter in front of it. Now, the lower incisor, number 2, lower incisor root apices should be more distal compared to the crown. Okay, and similarly, the lower canine root apex should also be more distal compared to the crown. And all the lower incisor apices must be in the same labiolingual plane. Now, the lower canine root apex should be more buccal than the crown, and the lower incisors should be slenderized by flattening the contacts. Now, let's have a look at the duration of the retention. Now, in terms of duration, retention can be either be self-retentive or no retention. It could be short-term retention. It can be medium-term or moderate or prolonged retention, or it can be permanent retention. Now, when a corrected cross bite has adequate overbite established, this is overbite, then the correction is self-retentive and no retention may be required. Now, short-term retention is 3 to 6 months full-time wear followed by another 6 months nighttime wear. Now, some of these situations where short-term retention can be used are corrected anterior crossbite with inadequate overbite, corrected posterior crossbite, serial extraction cases, correction of displaced teeth, and alignment of buccal canines. Medium term or prolonged retention usually means about 3 to 6 months full-time wear followed by another 1 to 5 years nighttime wear. Now, this is utilized in non-extraction class 1 cases when maxillary incisors are proclined, class 1 and 2 extraction cases, correction of deep overbite, correction of rotations, and correction of class 2, class 1, class 2 deep 2 malocclusion. Now, permanent retention. Permanent retention are usually obtained via fixed retainers or by making use of fixed prosthesis in cleft cases. Now, this is utilized in situation where the arch, especially the mandibular arch, has undergone expansion with treatment. Now, there is generalized spacing, meaning the arch length is more compared to the tooth material. Now, severe rotations, severe labiolingual positions of teeth. Now, midline diastema in otherwise normal occlusion, meaning you have a diastema but there is normally place frenum, there is no evidence of any odontomes or unerupted teeth, so otherwise it is normal. Now such cases the diastema correction will need to be permanently retained. Now cleft cases and periodontally compromised dentitions will also require permanent retention. Okay, these are the references for today's lecture. Thank you.